बिस्मिल्लाहिर्रहमानिर्रहीम। अस्सलाम वालेकुम। चलिए जी, हम अपना सेशन स्टार्ट करते हैं एज यूजुअल. We are going to start off with this scenario. So again, we will be discussing three case scenario. So the Dr. Amir will be an examiner. So in the first scenario, I will be the candidate. After me, Dr. Osman, then Dr. Numan Tasneem, they will be the candidate. Dr. Amir. Hello.
Okay, Dr. Shafkat, can you hear me?
Yes. Can you hear me?
Okay, Dr. Shafkat, 67-year-old male comes to you with a complaints of left-sided abdominal pain and bleeding, minimal weight. He is vitally stable. Abdomen is normal. How would you proceed in this case?
Sorry, because there was a distortion of the voice. So what I have heard, so it's a 67-year male with abdominal pain, but I couldn't hear you completely. Can you repeat your scenario?
Yeah, no problem. So 67-year-old male, he has presented to you with lower abdominal pain and bleeding per rectum. He has lost a small amount of weight. His examination is unremarkable. He is vitally stable, and abdominal examination is unremarkable. How would you proceed in this case?
So I will start off with the history. I will ask about the duration of the symptoms, particularly the pain, and I will ask about whether there any history of alter bowel habits or not, and ask the question related to the bleeding per rectum. Is it fresh blood? Is it mixed with the stools? And is there any other signs of the malignancy like spurious diarrhea or sense of incomplete evacuation? So, similarly, I will ask for the risk factor for the development of the CA. In these patients, I'm suspecting the diverticulitis, and also at the same time keeping in mind the carcinoma of the colon as well. So, abdominal examination, as you have mentioned, that's normal. There is nothing significant. So I will perform the digital rectal examination and do the proctoscopy to see whether there are any mass or is there any finding.
So digital rectal examination is normal, and on proctoscopy, you can see mass at the rectosigmoid junction.
Okay, so that means it's what is it? No, I would like to see what is it a friable? Is there any bleed on the touching or not? And is it a fixed mass? If I can feel with my finger. So can I take the biopsy? Is it within my reach or not?
Yeah, there is a clot on the over the surface of the mass, and the mass is around 2 by.
So it's palpable with the finger.
Yes, it's at the rectosigmoid junction. Though difficult to be palpable by finger.
Okay. So the next I would I would take the blood sample I will take the history for the risk factor for the development of the CA and family history and all those things. Then I will send the blood sample for the CEA level, stool for occult blood, and arrange the contrast and CT scan of the abdomen and pelvis with rectal contrast. And to see then depending on the results, then I will move forward.
Yeah, contrasting on CT scan is done. It shows no evidence of metastasis, and there is a mass at the rectosigmoid junction, around 2 by 3 centimeter. It confirms your findings of the examination.
Okay, so the next step would be I will arrange the colonoscopy for this patient. So I will discuss with the gastroenterologist and colonoscopy with the biopsy, and I will wait for the results.
So the biopsy shows adenocarcinoma of the. It shows adenocarcinoma.
adenocarcinoma. So again, then I will review the contrast and CT scan, which you have already mentioned that there are no mets in the liver. Is there any ascites or not?
There's no ascites.
No, the next step would be the staging. So I will get the contrast and CT scan of his chest as well. I will order the liver function test along with the CBC. So I will take this patient in the tumor board meeting and we'll discuss this case over there. And
Any other investigation that you would like to do for staging?
yes, the patient will require the PET CT scan as well for the to see whether there are any distant mets or not.
Okay, there are no distant mets. What would be your plan for this patient?
So then I would like to see on the CT scan, is there any local invasion or not? Because there are no distant mets. So is there any evidence of lymph node involvement? So if it's in the rectosigmoid, so lower down, so we will get the MRI of the pelvis as well to see what is the whether their lymph nodes are involved or not, and whether there's mesorectal fascia.
MRI shows, yeah, the MRI shows tumor extending beyond serosa and few lymph nodes palpable in the few enlarged lymph nodes in the mesentery.
Okay, so again, we discussed this case in the tumor board meeting, and most likely the recommendation will be to start up with the radiotherapy. So I will send the patient back to the oncologist for the new adjuvant chemoradiations and for downstaging the tumor.
Radiation or chemotherapy?
Radiation. New adjuvant.
First, you will give radiation.
Radiation.
Okay.
And what is the site on colonoscopy?
What would be the sequence of first you will give radiation or first you will give chemotherapy?
So it will be decided by the oncologist. So most of the time they because this rosa is threatened with the lymph node involved, and most likely they will give the radiotherapy. So that decision will be the oncologist decision.
Okay. So you gave the neoadjuvant chemotherapy, and the tumor has shrunk in size. What would you do?
Again, this case will be discussed in the tumor board meeting. And again, I would like to review the previous colonoscopy report. What is the this distance from the anal verge, the tumor distance from the anal verge, and afterwards, again, restaging will be done to see the extent of the regression. So next step would be planning for the surgery. I would like to know what is the continence status of the patient and the fitness of the patient to undergo the anesthesia or the investigation required to get the pre-anesthesia assessment. Can you hear me? Can you hear me?
Okay. Yeah, there was some distortion in the voice. Can you repeat?
Yes, I would like to know what is. I would like to review the colonoscopy reports. What was the distance of the tumor from the anal verge, and I will ask the question later the continence status as well. And this patient will require the restaging, and afterwards, this patient will be the tumor board's recommendation will be to proceed with the surgery.
The tumor is at rectosigmoid junction. What surgery?
Okay, it's a rectosigmoid junction. Okay, offer. So the surgery will offer be it's a interior resection, high interior resection with the.
Okay, what is the minimum distance for which you can do low interior resection?
It depends upon the again the histopathology reports a well differentiated adenocarcinoma. It's the distal margin should be 5 centimeter. Well differentiated. Oh, sorry. sorry, I can mix it up with the plurally differentiated. It's at least a 2 centimeter margin sufficient for the well differentiated adenocarcinoma.
Okay, Dr. Shafkat, thank you. अभी किसने करना है?
मैंने करना
उस्मान ने?
जी सर.
अच्छा जी. Dr. Usman, 64-year-old male presents to you with upper abdominal pain and hematemesis.
Okay. First of all, I will like to get the thorough history from the patient, whether there is a fresh bleed or there is what is the color of the bleed, and is it projectile or not. I will take history about brief history about any history of smoking, alcohol, acid, previous history of gastritis.
There are
And
no signs of liver dysfunction.
okay, I will resuscitate the patient. While taking the history, I will simultaneously resuscitate the patient by ABC protocol. Patient, I will maintain his airway because there he is vomiting. His airway is at risk. If he is conscious, then I will ask
Yeah, the
my colleague.
patient is conscious and
Okay.
his vitals are stable.
I will ask my colleague to pass two large IV
He
cannulas.
is having melena and hematemesis. He is having hematemesis and melena.
After resuscitation,
Otherwise, he is well.
after resuscitation, I will talk to the gastroenterologist to see arrange for his upper GI endoscopy. I will continue my resuscitation. I will send blood sample for a complete picture, coagulation profile, liver function test, hepatitis BC to see the cirrhosis. Any evidence of portal hypertension, I will examine his abdomen. If whether is there any stigmata of portal hypertension or liver compromise, I will take history of drugs. And I will then arrange upper GI endoscopy and request gastroenterologist to see what is the source of bleeding. Is there any erosions, any ulcer? I would like to know the findings of upper GI endoscopy. Is there any active?
Upper GI endoscopy is done, and there are some dilated vessels visible in the region of the fundus, and there is no ulcer, and there is no mass.
Okay, it means that patient is there is active bleeding from the this gastric fundus.
Yeah, there are vessels in the gastric fundus.
Okay, and is there any
They are
history
not
of?
actively bleeding, but there is a clot, and
Okay,
there are few dilated vessels.
then I will request my gastroenterology colleague, because it can be an AV malformation that is known as Doliphy's lesions, and I will request my gastroenterology colleague to, if he can clip the vessel, or if he can give adrenaline or sclerosing agent into the submucosa to stop the bleeding. And I will recess after gastroenterologist. I will also request gastroenterologist to see the up to the duodenum. Is there any other bleeding point or not? And I will give transamine to the patient.
There are no bleeding points.
And if a gastroenterologist is able to,
Okay, there are no bleeding points, but what is the difficulty while performing gastroscopy at the level of the fundus?
because the fundus is a hidden area, and technically gastroenterologist has to do U maneuver. It has to see upward inside the stomach. It has to retrograde, see the fundus from lower upside, and it is technically challenging, and very experienced gastroenterologist is required to do the clipping or some interventional procedure in area of fundus.
Okay. What apart from clipping, what else can be done in this case?
Instead of clipping, sclerotherapy can be done, or otherwise, if all
Sclerotherapy is difficult because you mentioned that it's a difficult area.
yes, then we can do the limited resection. Or if gastroenterologist fail, then we can do the resection of the stomach of affected area and under the gastric mucosa. We have to surgically then treat the patient if a gastroenterologist fails.
So what would you do? You would go for wedge resection?
Yes, I will go for wedge resection, or I will ask the gastroenterologist to mark the place, and I will do the wedge resection and underrunning the mucosa and wall of the stomach.
Okay, Dr. Usman, thank you very much. Sir Numan? Sir, can you hear me? Sir, 67-year-old male was operated for left-sided colonic mass by Dr. Shafkat, and he has come to you 6 months later with a swelling at the site of the wound. How would you proceed in this case? What's your suspicion and how would you proceed?
My suspicion is he has developed an incisional hernia, and I will start with history. I will take all his relevant history when he was operated and his symptoms previous to
what history would you take? Can you enumerate the essential points?
Yes. Apart from the history of previous surgery and previous symptoms, I will ask about this swelling that when he has post-surgically, when he first developed the swelling, after how many days or months, and what made him to notice the lump, and what are the aggravating and relieving factors of the lump, and is there any bowel habits, any urinary or bowel complaints, and any relation to activity, any relation to exertion, and I will ask about any weight loss, and ask about any discharge or from the operation site. These will be my main points. Also, I would like about his profession.
What would be the
sorry, what will be the
most important thing while taking this history from the patient who has developed incisional hernia?
I think the most important will be his the factors, aggravating factors or relieving factors for the lump, and his profession or his job, or what activities he is doing post surgically. And apart from that, I would like to ask the operating surgeon also that what type of closure he did on this patient, and what suture was used, and what technique he used for the closure.
It was closed. Mass closure was done with Pauline one.
Okay, so he may have developed incisional hernia because of maybe malnutrition, or he may have some wound infection at the time of post-surgical.
There was no wound infection.
So he may have some chest infection. He may have chronic bronchitis or coughing problem, or he may have. I'll also ask about any urinary problems if he has any difficulty in passing urine, or prostatism symptoms. And I will also like to ask about his smoking history. Is he a smoker? That is also a contributing factor to.
Yes, the patient has some constipation, and he also gives history of chronic coughing.
Okay, so these are the risk factors for development of this hernia, and I would like to optimize these risk factors first. I will like to request my medical specialist colleague to look after his chronic bronchitis problem. And for constipation, I would like to review his diet plan, discuss with me.
You will do this first, or you will just perform the surgery and then send the patient to?
If it is a non-complicated hernia, if it is just an hernia with no pain, no obstructive symptoms, or no signs of any impending strangulation, then I will first try to optimize his risk factors, like this chronic bronchitis.
Okay, so you have optimized the risk factors. What surgery you would do in this case?
So I would like to, I will do a thorough pre-anesthesia assessment of the patient, and I will get his baseline along with a CT scan to see any recurrence of the growth or any metastasis, because he has undergone a surgical section for tumor. And afterwards, I would like to do for this incisional hernia.
Pardon, you would like to do pre-peritoneal mesh repair?
Yes.
What are the risks involved once you go for incisional hernia surgery?
The risk involved will first, as he has previously undergone a major surgery, so there will be multiple gut adhesions with the peritoneum and with the abdominal wall. So I have to start the laparotomy very carefully, preferably start from a virgin area and do an adhesive lysis first. Secondly,
okay, you did the laparotomy, and the size of the defect is 5 by 7 centimeter. What is your plan for this patient?
Yes, I will try to develop a plane between the linea alba and between the rectus and the peritoneum for the placement of mesh. And I will close the peritoneum, and I would like to place a mesh, a large mesh, preferably 15 by 15 centimeter mesh in the pre-peritoneal space. And I would like to close the rectus over the mesh.
What is posterior component separation?
Yes, posterior component separation is, I think, in which I have to study it. I forgot it, sorry.
Okay. Have you ever performed posterior or anterior component separation surgery?
I have seen it. I haven't performed it. I have assisted it. I have assisted it.
Okay. Dr. Noman, thank you very much.
Thank you. अच्छा ये क्या होती है जरा बता दे जरा वैसे कंपोनेंट्स पोस्टीरियर और इंटीरियर.
सर पोस्टीरियर कंपोनेंट सेपरेशन जो है ना, इसमें बेसिकली आपने ये करना है कि वही मिड लाइन से खोल के तो जो लीनिया एल्बा है उससे 1 सेंटीमीटर पीछे जो है आप इंसिजन लगाते हैं, और जो पोस्टीरियर शीथ है उसको अलग कर लेते हैं लीनिया सेमिलरिस से पीछे तक जाके तो रिलीज कर लेते हैं, यानी ट्रांसवर्सस एब्डोमिनस जो है ना उसको जो रिलीज कर लेते हैं उसको, और उसका रिलीज करने से ये फायदा होता है कि फिर वो चूंकि उसके साथ नहीं रहती तो उसमें स्पेस बन जाती है। ये इसमें बड़ी अच्छी तस्वीर बनी हुई है जो ये क्लिनिकल सिनेरियोज वाली किताब है इसमें भी, और साथ जो है ना ये एक आध और बुक थी उसमें भी मैंने देखी थी बड़ी अच्छी। तो ये सर इसमें ना 3 सेंटीमीटर मिल जाता है, दरमियान में 5 सेंटीमीटर मिल जाता है, यानी 6 to 8 सेंटीमीटर ऊपर मिलता है, 6 to 8 सेंटीमीटर नीचे मिलता है, और 10 to 12 सेंटीमीटर दरमियान में मिल जाता है, या 8 to 10 सेंटीमीटर दरमियान में। इंटीरियर कंपोनेंट सेपरेशन में थोड़ा कम है, 1-2 सेंटीमीटर, और पोस्टीरियर में ज्यादा है। इंटीरियर में क्या करते हैं कि उसी को जो है वो इंटीरियर शीथ को अलग कर लेते हैं, पीछे तक रिलीज कर लेते हैं लीनिया सेमिलरिस से
हाँ, लीनियर सेमिलर के ऊपर इंसाइज कर लेते हैं उसको ना, ज्यादा आप देखें छोटा सा देख के ना उसके भी कर सकते हैं, जैसे ऊपर तक ले जाए, सब जो कॉस्टल मार्जिन तक ले आते हैं ना,
जी जी सर, ये पूरी जो है ना
हाँ
सब कॉस्टल मार्जिन और नीचे प्यूबिक सिम्फिसिस तक, ये पूरा
हाँ,
ऊपर से नीचे तक इसको रिलीज करना
लीनियर
होता है।
सेमिलर वाली लाइन के ऊपर रखते हुए
जी, और फिर उसमें रिलीज करने के साथ ही होता है कि ये फिर दरमियान में
करीब आ
आराम
जाएगा,
से बंद हो जाता है,
क्लोज हो जाएगा।
और फिर आप इसमें ना मैश लगा के तो आप इसको ऊपर से रीइंफोर्स कर सकते हैं। तो ये है ये, लेकिन पढ़ भी लीजिएगा सर, इसकी वीडियो भी देख लीजिएगा, ये पूछ सकते हैं। तो बाकी आप लोग माशाल्लाह सर अभी सही रिस्पॉन्ड कर रहे हैं। सिर्फ ये है कि सर जो जब आप मिलिग्नेंसी का बताते हैं तो फिर मिलिग्नेंसी का पहले बताएं, आपने डायवर्टिकुलाइटिस पहले बताया, फिर मेरे ख्याल मिलिग्नेंसी बताया, तो वेट लॉस का भी मैं बता रहा हूँ तो पहले मिलिग्नेंसी का बताएं। फिर रेक्टोसिग्मॉइड जंक्शन का वो है तो फिर वो यानी कम से कम 4 सेंटीमीटर एनस और 12 सेंटीमीटर रेक्टम, तो 15-16 सेंटीमीटर ऊपर है ट्यूमर ना, तो उसमें तो आपको फिर वो फिंगर से
दूसरा
नहीं पलपेट होगा।
नहीं, फिंगर नहीं, प्रोक्टोस्कोपी में विजिबल नहीं आएगा ना, रेक्टोसिग्माइड जंक्शन का तो उसमें भी नजर नहीं आएगा।
वो लंबी प्रोक्टोस्कोप पे नजर आ सकता है,
हम्म
लेकिन ये है कि फिर वही है कि सिग्माइडोस्कोपी और वो
हम्म
क्लोनोस्कोपी उसके
हम्म
ऊपर, तो वो अच्छा हो गया। बाकी फिर आप थोड़ा सा उसमें भूल गए थे, एमआरआई
हम्म।
और जो ये वाला ट्रांसरेक्टल
हम्म।
अल्ट्रासाउंड वगैरह जो है उसका, वो
अब
थोड़ा सा याद रखें कि टी स्टेज को आपने करना है डिटरमाइन। और सर बाकी जो है आपने बड़ा अच्छा बताया, सिर्फ ये था कि उसको जब जंक्शन है तो फिर आप उसको लो इंटीरियर सेक्शन बताएं,
हम्म,
और फिर इधर ना करें। तो इसी
नहीं,
तरह
दो
ये कर दिया कि जो वो सैनो एक्रिलेट जो है
नहीं,
वो
दो
जो,
इंटीरियर सेक्शन क्यों? देखें रेक्टोसिग्माइड जंक्शन का ना, तो
नहीं
रेक्टोसिग्माइड
नहीं इंटीरियर
जंक्शन
सेक्शन है
हाँ
रेक्टोसिग्मॉइड जंक्शन का, तो वो है ना कि उसमें
इंटीरियर, हाँ
इंटीरियर सेक्शन होगा, सिग्मॉइडेक्टमी होगी और
हाँ
इंटीरियर सेक्शन होगी,
बिल्कुल, इंटीरियर सेक्शन जो
प्रोक्टोसिग्मॉइडेक्टमी।
हाई इंटीरियर सेक्शन कह रहे हैं उसको, या
जी,
इंटीरियर सेक्शन बस कह रहे हैं, ठीक है।
तो बाकी जो है वो हाई इंटीरियर सेक्शन होगी या वो इससे
हम्म
प्रोक्टोसिग्मॉइडेक्टमी,
हम्म,
क्योंकि सिग्मॉइड और उसका दोनों का जंक्शन करनी, तो ये है। बाकी उसमें कीमो रेडिएशन को सर देख लीजिएगा, रेडिएशन जो है ना वो ये है कि अगर आपने फॉरेन सर्जरी करनी है तो फिर मेरे ख्याल रेडिएशन है, और
दो है
वैसे जो
इसमें,
है
इसमें
जो
दो है चीजें,
बाकी।
एक है शॉर्ट कोर्स है, शॉर्ट कोर्स मतलब
जी
वो
जी
उसमें
सर।
देते हैं 5 डेज का कोर्स होता है, और
हम्म।
उसके हफ्ते के बाद फिर सर्जरी होती है। वो होता है कि आप उस पे मतलब लिम्फ नोड इन्वॉल्व नहीं है, आपका सिर्फ ये थ्रेटन्ड है कि जो मेसोरेक्टल जो आपकी जो टीएमई करनी है ना, कि वो आपको प्लेन लग रहे होते हैं कि ये थ्रेटन्ड तो नहीं है, सस्पिशन के ऊपर करते हैं टू स्टेरलाइज द एरिया। ये 5 डेज का कोर्स होता है, फिर आफ्टर 1 वीक कर देते हैं। जो दूसरा होता है ना लॉन्ग कोर्स, वो देते हैं, ये 6 वीक का कोर्स होता है, 6 to 8 वीक रेडियोथेरेपी। उस सर्जरी जो होती है वो आफ्टर फिर 8 वीक जो होती है, वो होता है जिसमें लिम्फ नोड इन्वॉल्व है, और सिरोजल जो है ना, T4 जो ना, जैसा ये सिरोजा भी हुआ हुआ था ना इसका, तो
अब इसमें ना सर मेरा ख्याल है कि
हाँ,
कीमोथेरेपी जो है वो पहली
अब
ऑप्शन आएगी,
अब अगेन
क्योंकि
अगेन अब ये
कीमोथेरेपी में अभी, क्योंकि
हम्म,
कीमोथेरेपी में जो न्यू एडजुवेंट कीमोथेरेपी है ना उसमें तो वो अभी इसने वो जो आपने रिस्पॉन्डर वाला पूरा वो है ना कि जी 20% में बिल्कुल खत्म भी हो जाता है ट्यूमर, तो वो
हाँ
न्यू एडजुवेंट कीमो रेडिएशन में से
सी
कहने कीमोथेरेपी जो है वो मेरे ख्याल पहले आएगी, इसका इतना उसमें रोल नहीं आएगा जब लिम्फ नोड इन्वॉल्वमेंट है तो।
अब इसमें इसमें थोड़ा
हाँ
सा
लोकली जो है ना सर।
कंफ्यूजन जो मुझे थी ना, ये आपकी उस पे जो कि जी प्रोक्टोस्कोपी पे आ गया। अभी ये थे कि रेक्टल रेक्टल की बात क्या है, टॉकिंग अबाउट रेक्टल या रेक्टोसिग्माइड, इसमें थोड़ी सी थी। तो जो कोलन का जो अगर मैस है तो वो फिर डिफरेंट हो जाता है, उसमें कीमोथेरेपी है, नॉट रेडियोथेरेपी। अगर प्योर रेक्टम के अंदर है तो फिर उसमें रेडियोथेरेपी उसके अंदर है। तो वो थोड़ा सा जो है ना वो उसमें था कि ये रेक्टल सीए है या
ये
रेक्टोसिग्माइड।
सर देख लेंगे इसको, कल डिस्कस कर लेंगे।
हम्म हम्म
हाँ, लेकिन मेरा ये ख्याल है कि इसमें पहले कीमो रेडिएशन कीमोथेरेपी है।
हम्म हम्म
कीमोथेरेपी है इसमें मेरे
होता है तो
ख्याल
पहले
पहले,
ये
बाकी ये
क्लोनोस्कोपी
उस्मान
और
जी
इसमें
सर।
कोई चीज, और कोई चीज?
मैंने कहा जब आपका मैस आ जाता है तो पहले सीटी स्कैन होता है या पहले क्लोनोस्कोपी होती है आइडियली?
क्लोनोस्कोपी होनी चाहिए सर, वो भी सर ने जो है ना थोड़ा सा सीक्वेंस लेट किया, क्योंकि अब वो सीटी सर
यही
ने
कह रहा है,
पहले
पहले
करा लिया,
क्लोनोस्कोपी।
फौरन क्लोनोस्कोपी होनी चाहिए पहले, और फिर
Colonoscopy
स्टेजिंग
and
इन्वेस्टिगेशन में
biopsy.
सीटी स्कैन आना है।
Colonoscopy and biopsy for tissue diagnosis.
फिर वो
फिर
स्टेजिंग में
CT
आनी चाहिए सीटी स्कैन ना, सीटी स्कैन उसके बाद आनी चाहिए, पहले नहीं आनी
सीटी
चाहिए।
में कंट्रास्ट वगैरह देते हैं, फिर वो चीजें जरा वो हो जाती हैं, गड़बड़ हो जाती हैं।
जी सर। तो बाकी इसमें सियानो एक्रिलेट का रोल है उस्मान, वो जो है ना ग्लू,
सही
वो
है,
लग जाता है ऊपर, और वो
ठीक है,
उसका ये एडवांटेज है कि वो उसको वेसल को
बंद
वो
कर
कर
देता
देता है, फाइब्रोज कर देता है, और वो कर लेता
है,
है।
सही है। क्लिप
तो
है
ये
और
है,
ग्लू है, क्लिप है और ग्लू है।
क्लिप और ग्लू, हाँ जी,
हम्म,
क्लिप है और ग्लू है। इंजेक्शन वगैरह लगाना थोड़ा सा मुश्किल है, और बैंड करना भी मुश्किल है।
बैंड तो मुश्किल है, नामुमकिन है ना, क्योंकि बेसिकली तो ये वो सब म्यूकोजल वेसल होती है, एवी मैलफॉर्मेशन, तो बैंड तो इसमें नहीं है। क्लिप लिखा हुआ है, और ग्लू जो है ना, सायानो एक्रिलेट ग्रुप, जो ग्लू है वो।
बाकी
ठीक हो गया सर।
उस्मान सिंपल चीजें पूरी किया कर, जैसे फोलिनी तूने मेरे ख्याल में बताया, फोलिनी मेंशन किया, और ये पीपीआईज वगैरह और इस तरह की चीजें, ये मेरे ख्याल में मेंशन कर देनी चाहिए।
ठीक है सर।
जनरली सर वो
अ,
तेज तेज पूछते हैं, इतना टाइम नहीं देते, लेकिन ये है कि जरूर आप मोटी बात कर दें, रिससिटेट करूंगा, आई वुड
हम्म,
रिससिटेट, गिव फलाना, दो तीन चीजें
हम्म,
इकट्ठी बात बता दी। तो चले सर,
ठीक है।
अपना ख्याल रखें बस, जो है अभी
सर
जो
आमिर
है।
अभी तक इसका जवाब नहीं आया, हफ्ता हो गया अभी तक उनको जाना, मैंने मेल की हुई है। क्या करूँ, उनको फोन करूँ, क्या करूँ, या वेट करूँ एक दो दिन?
फोन मैंने कहा